Pooja, you called Dr. Anita?
Ma'am, Dr. Anita didn't pick the call, ma'am. I've tried twice, so I'm just seeing if she'll call back. We'll start the program, ma'am. Ma'am will join us.
Yeah.
Yeah, I'm going to make it live.
Yeah. Good afternoon, Sharda, ma'am.
Good afternoon.
Asha, ma'am, I had joined Dr. Sharda, ma'am, for a training program. She's a great teacher.
So we are live now.
Click.
Good evening and Shubha Basant Panchami to everybody.
Thank you, ma'am. Wish you the same.
So good evening, all the faculties and delegates for the Core Connect live webinar. That is Searchlight Series 10, which is on the topic of updates in post-menopausal bleeding, and which is initiated by the Cancer Prevention and Relief Society in association with Bangalore, Baramati, Belgaum, Bellary, Bengal, Berhampur, Bhagalpur, and Bhandara Option Gynae Society. So right now, it's my privilege to welcome our convener, Dr. Sujay Sri Sangeeta. Ma'am is currently founder secretary of Bhimavaram Ops and Gynae Society, and right now, ma'am is practicing as a consultant ops and laparoscopic surgeon at Sheshadri Hospital, Palakal. And ma'am has done so many paper presentation on various conferences, and associated with the Vikasam, that is the awareness program for the adolescents girl for the on the menstrual hygiene. Welcome, ma'am, and I request you to please take this webinar ahead.
A very good afternoon to all the faculty who have logged in today, and also to everyone who's watching today's program. Yeah. So it's a great privilege for me to introduce Dr. Asha, ma'am. Yeah, could I request the others to please mute? There seems to be a little disturbance, ma'am. Yeah, thank you so much. Yeah, so it gives me great privilege to be introducing Dr. Asha, ma'am, who has vast experience of 34 years in the Department of Obstetrics and Gynecology. Madam's current posts are she's the director of SMSA Hospital, Raipur. She's the medical director, Cancer Prevention and Relief Society, elected member, CG Medical Council, vice president, IMA Chhattisgarh, zonal chair, Foxy Food, Drug and Medico-Surgical Equipment Committee, West Zone, chairman of Mission Pink Health, IMA Raipur, executive member, ISCCP. And Madam's previous posts were, she was the immediate past president of Raipur Obstetric and Gynaec Society, past secretary IMA Raipur, and past president Rotary Club of Raipur North. So ma'am's fields of interest are saving the uterus, fetal medicine, critical care, preventive oncology, and colposcopy, which is relevant to the topic today. So I request ma'am to please take over and proceed with the program.
Welcome to this 10th episode of Search. We begin by invoking the blessings of the divine. Today is Saraswati Puja, and we request Ma Sharda. We have Madam Sharda with us today to bless us all and start the program. So, Mehul, please continue.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति
welcome to this webinar. Without wasting much time, after invoking the blessings of the divine, I would like to introduce my chief guest, Dr. Sharda Jain ma'am, who has kindly consented to be with us today evening in spite of a very, very busy schedule. She is fondly known as the teacher of teachers. She is the director of Life Care Center and Life Care IVF, founder and secretary general of Delhi Gynecologist Forum, a body of over 2,500 members, founder and chairperson of North India Gynecologist Forum, which covers 10 states, NM's ethical committee member and apex body of 14 lakh modern medicine doctors since 2018, included her in top 20 most influential women in healthcare in India in the year 2022. She is a DMC expert since 2009 till date, passionate medical activist, has given leadership role in removing female feticide, movement of anemia, save uterus, save ovary, and every mother counts, etc. Given concept of Janani Suraksha Yojana and Asha worker to Government of India, she is spearheading the movement of doctor safety, medico-legal awareness, unity of North India gynecologists, and she is decorated with many lifetime achievement and living legend awards from many bodies, including LHMCAA, FOXY, DMA, DGF, WOW India. More than that, she's an ardent promoter of vaccination to prevent cancer, and that is how I have known her for many, many years. Welcome, ma'am. Today, the topic is postmenopausal bleeding, and we would be honored to have your blessings on that.
Dr. Asha, I'm very happy that you've invited me as a part of this academic activity on this a very auspicious day dedicated to Ma Saraswati, a deity who is known for knowledge and Vivek Detya mein. So I think, the topic chosen by you is very important, of postmenopausal bleeding. And as an elder member here, I need to share some of my knowledge and insights. I will say that postmenopausal is not uncommon. We definitely find it happening around in 15% of patients. But when it comes to underlying serious problems, one can say that endometrial hyperplasia is, which is a precancerous lesion, is seen in around 10 to 15% of patients, and another 10% it is underlying uterine malignancy. At the same time, I think, the growing interest of atrophic vaginitis and atrophic endometritis also need to be known these days. Recently, we've started getting investigation for tuberculosis in atrophic endometritis, and I find a good number of patients have tuberculosis, and they were mainly investigated by the doctors themselves on themselves, and we found, once you treated them for anti-tubercular treatment, things disappeared. Great number have, you can find benign polyps and all are creating problems in, again, good 30% of patients. And again, here the treatment is simple. The only thing which we need to rule out is endometrial hyperplasia, and each one of us should know about it. What is the significance of it? Simple hyperplasia, malignancy is 1%. Complex hyperplasia is 3%. And whenever there is an atypia, simple hyperplasia with atypia, the malignancy is 8%. But if it is a complex hyperplasia with atypia, the malignancy rate is around 35%. So I think, these particular things must be known. As far as an endometrial cancer is concerned, I think, all of us know about things are simple. But I think in these patients, good follow-up is required. Recently, a very senior doctor who is the president of very close by society of FOXY lost her life to endometrial cancer. Well, I've not seen in my long experience that anybody dying of secondaries of endometrial carcinoma, because it's such a slow-growing tumor. But, when you find it happens, it happens. She had stage 1, grade 3 disease, where we know that the underlying lymph node involvement can be as close as 30%. She had all the surgery done. She was on a follow-up, and then suddenly she found there were secondaries. And she did not give it in 6 months' time. The histopathology was not bad. So what I find, the follow-up is very important, and everything we should take seriously. And whether we are doctors ourselves and we do not belong to that particular category. That's something I just wish to know, and I think I would like to know from each one of you. You don't find anything. Patient is having a recurring problem, twice it has happened. What is our policy? Patient come to us and they say that, Dr. Jain, get our uterus out. I do that. If it is a recurring problem, I would like to know what is your opinion about the same. We haven't found anything. No atypical hyperplasia, no malignancy. What is your viewpoint about it? And I think, I've also not had any explanation, and people and experts ask me why the uterine malignancy is 2% in your country and 2 or 3%, and in Japan it's so much low. Why in US it is 30%? Why in the UK it's 15%? I have no explanation. Why it is the problem of the affluent class and why not of a rural area? Again, I have no explanation. So I think probably I will love to know about various myths and misconceptions about postmenopausal bleeding and how to go about it. Here, I just wish to tell you that the recurrence now, knowing in couple of my patients and the recent doctor who lost her life, is that, you must know that once the remission has taken place for 6 months, and it's on a follow-up, then it is a recurrence. I will again like to get enlightened with so many senior people around. What is the chances of recurrence and uterine malignancy when the complete surgery has been done? So with these remarks, I can definitely say that a couple of answers I still do not have. But till now, we thought, as for the postmenopausal bleeding, is not a very simple problem. But at the same time, we should not have a very conservative treatment as far as the uterus removal is concerned. I would like to have opinion of other people. I think I'm subject to things. So with this thing, Asha ji, thank you very much for inviting me here. And I don't have any more to comment than this.
Thank you, madam. Thank you so much. I think the answer to some of your questions is the immunohistochemistry and tumor markers. So now I would request Dr. Neerja Bhatla ma'am, please video on karen. Mehul, would you please share her CV? Anita ma'am is yet to join us. I don't see her, but Dr. Neerja is here. And I would like to introduce Dr. Neerja ma'am. She is one person who needs absolutely no introduction. She is known in India and out. She's a well-known name in gynec oncology. She is the Vice President, Foxy North Zone, Vice President, National Academy of Medical Sciences, India, and Council member of ASGO. She's a former professor and head of the Department Obstetrics and Gynecology, head of WHO Collaborating Center for Cervical Cancer Prevention and Research at AIIMS, New Delhi. She's past chairperson of FIGO Committee for Gynec Oncology 2015 to 18, past Secretary General IFCPC, and past President AOGEN. Professor Bhatla has conducted trials and published extensively on various aspects of cervical cancer prevention, including HPV epidemiology, HPV vaccination, screening, and treatment with special reference to low-resource settings. She's a member of the Technical Expert Group for WHO's Cervical Cancer Elimination Initiative. In 2021, Dr. Bhatla was awarded the Shobha S. Wenger Distinguished Chair of Gynec Oncology at AIIMS, New Delhi, and the FRCOG UK. She is the recipient of the WHO IARC Award for the Women in Cancer Research 2023. We are extremely honored to have you here, Dr. Neerja, and would seek your words of blessings and also an answer to Dr. Shada's questions. Over to you, Dr. Neerja. Can't see her.
I don't think Madam is logged in either. She was here a short while back. I'll try calling her.
Dr. Sarita, would you just give a call?
I'll call.
Okay. Yeah. Yeah, sure, ma'am. Ma'am, I spoke to Dr. Neerja. She said she accidentally got logged out. There's an issue with the network. She'll log in shortly. She asked us to proceed with the program.
Okay. Sharda ma'am, when Neerja ma'am will answer, you'll get your answers. I'll share the recording if you have to leave. Okay. Otherwise, I think she should be logging in shortly.
Perfect, perfect.
So I think we proceed with the scientific session now. We are almost on time. So Sujayshri, requesting you to introduce the chairpersons.
Yeah, the chairperson for the first session, Dr. Shubha Ramarao. Madam is the president of Bangalore Society of Obstetrics and Gynecology. She's the senior consultant and head of department of Martha's Hospital. DNB teacher, guide and examiner, life member of BSOG, AGOI, BMS, vice president, BMS. She's also the faculty at national and international conferences. Madam, welcome to today's program. Next, we have Dr. Rajesh Kokare. Sir is a senior consultant obstetrician gynecologist at Kokare Memorial Hospital, Baramati. He's also the honorary consultant for Chaitanya Hospital, Gondawala. He started the first advanced laparoscopic surgery center at Baramati and has done more than 5,000 laparoscopic surgeries. Commendable, sir. And sir has also started the Save Girl Child mission in Baramati. He has also started the Anemia Chale Jao campaign at Baramati. He's received numerous awards. He's been nominated for Anandibai Joshi Puraskar from Pune Zone. He has received Maharashtra Patkar Sangh State Award, Gayatri Puraskar, Jaipur, numerous awards, sir. We're really happy to have you with us today, sir.
Thank you.
Next, we have Dr. Sumaya Firdaus Patel. Madam is a consultant obstetric gynecologist with experience of 28 years. She is the medical director of City Hospital, Belagavi, president of Belagavi Obstetric and Gynecological Society, joint secretary of Indian Menopause Society, Belgaum chapter, and her areas of interest are high-risk obstetrics and menopause. Madam, welcome for today's session.
Thank you.
I request Dr. Asha ma'am to introduce the speaker for today's session.
The chairpersons will introduce. Neerja ma'am is here. Neerja ma'am, if you have heard what Sharda ma'am has said, would you please give your blessings and answer those questions?
So I'm sorry I got knocked out in the middle of that and I missed some of what Madam had just started when I got a problem. So I would be happy to hear the questions again. But first of all, my greetings to all of you, to all the seniors and the respected dignitaries of this webinar, as well as to the distinguished delegates. And Dr. Asha, I really compliment you for choosing this topic, which is such an important topic, because postmenopausal bleeding is becoming an epidemic, really. And every gynecologist, I'm sure, must be seeing one case on each clinic, because it is, first of all, the women are living longer. And then secondly, we have all these metabolic factors that are causing them to be at high risk for many of the endometrial conditions particularly. So although there will be only 10% who will really have any sinister cancer-related problem, but we don't know who are the 10% until we evaluate them. So this message should be very loud and clear that it is never normal to have bleeding after 1 year. I recently saw a patient who had been a very well-to-do patient with good access to healthcare, who had postmenopausal bleeding with a history of cancer endometrium in her mother in the city of Mumbai. And the doctor told her, oh, I think you've just started having your periods again. So it's really, really bad when that kind of message goes and she has an endometrial hyperplasia. So I think we have to, each one of us, make an effort to make sure all the people around us are aware about this and they get evaluated instantly when they have an episode. Especially for cancer endometrium, They have reported abroad that women will always seek help within 3 months because it is such a dramatic symptom. And that's one of the important reasons why we catch it early while it is still operable. I saw another patient who didn't react to it for a year. She was embarrassed to tell her family, even though she was educated. And by the time she came, it was a serous variety and it had spread even inside the peritoneum, which is so rare. So these are the things which make you very sad and feel somewhere we are missing our duty if patients don't realize how much we can help them. So I will stop here because
Dr.
I really
Sharda
do
ma'am,
want
would
to
you
hear the
repeat your
talks. But
question?
yes, I want to hear Madam's questions and comments.
This question is why we Indians and Japanese have low uterine cancer and why US has 30% and UK around 10 to 12%. One thing. Do you still think that this is a cancer of an affluent class?
Madam, this is not now true. We are now fast increasing. If you look at the graph, there's a rapid rise now in the CA endometrium rates. And maybe some of the speakers can also shed light. So I think US always had this problem of metabolic syndrome. Their obese women were far more obese than our most obese ones. So now, in fact, their obesity is a little bit curtailed after they controlled the portion sizes in their meals. But ours are increasing, our obesity rate is increasing, our diabetes, our metabolic syndrome parameters. So we are seeing this rise in CA endometrium and changing lifestyles. I think the Japanese diets, our inherent Indian diets are very healthy diets. Very healthy diets. But unfortunately, we are going the junk food way. So with that...
Another question. Once you rule out the benign part of his atrophic vaginitis, atrophic endometritis, and a whole lot of polyps problem is also gone. Cervical things are ruled out, benign and things. Now, once you find there is a recurrent problem, what is your catch on it? Whether we should, if somebody is asking them for a uterus removal, what is your say? I say uterus removal. What is your say?
Yes, madam, I agree with you. And there are two things to this. One is, of course, that the patient don't want to each time have to go through this cycle of getting an ultrasound, getting an endometrial aspiration, getting a hysteroscopy, all of these things. But the other also very real possibility is that we have actually missed sampling something which is of significance and which is possible. I had a patient who had an endometrial hyperplasia. She did not have any bleeding. Just detected thickened endometrium in a routine ultrasound post-menopausal. As per guideline, you can leave her alone, but we did her endometrial aspiration and it was showing a proliferative. We left her alone. Again, she did the follow-up. It had become even thicker, still no bleeding. So we said that, no, this is not a good thing, sampled, and it was now showing an atypical hyperplasia. So we said, you must get a hysterectomy done, which she did, and eventually our pathologist, also hats off to Dr. Sandeep Mathur, would khod ke, in one corner he found a well-differentiated carcinoma. So when the guideline says you need not worry if she hasn't bled, what it means is that when she bleeds, you will still catch her in stage 1 probably. So that is why they made guidelines like that. But I think we cannot ignore a thickened endometrium, even if the patient has not bled. If you want to be on the safe side, do one endometrial aspiration.
Dr. Shubha Saxena, one of the president of Obstetric and Gynecology Society of OXY, she had no postmenopausal bleeding. She had a small cyst, and her CA125 was just 67. She got herself operated, got the uterus removed. She never got the DNC done because she never had postmenopausal bleeding, and the TVS did not show that there is a thick endometrium. It was just about 2 to 3 millimeter. Madam, it was endometrial carcinoma, and it had invaded more than half of the endometrium. And then, knowing that there can be lymph node problems, she got extensive surgery done. After that, she had gone to Pune, got it off from surgery there, and still, we lost her in just a matter of 9 months' time. Secondaries.
So most likely, she must have had a serous variety, because the serous varieties do tend to spread and they go to the lymph nodes also very fast, and they don't respond so well with the adjuvant also. So that is why it is, not to be ignored, definitely not to be ignored.
So, thank you, Dr. Nirja. Thanks a lot. Sharda ma'am, namaskar. So now we proceed to the session and requesting chairpersons, please introduce ma'am.
Yeah, thank you very much. Shall I take the introduction?
Yes,
Yes.
ma'am.
Yes, ma'am, please do.
Thank you very much. Special thanks to Dr. Asha Jain, for inviting me here to be chairing this session. And it is indeed an honor to be here among all you august, teachers and practitioners. And I must say that all of you are really doing yeoman service towards women, by being part of the FOXY and the local bodies and doing so much for the women's health. So it's indeed my pleasure to introduce Dr. Sarita Shamsundar, who is an FRCOG. She is a consultant and professor at the Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. She is a board member of the International Federation of Colposcopy and Cervical Pathology, and she organized Asia's first World Congress of Colposcopy and Cervical Pathology in July 21. She has been chairperson of the Oncology Committee, Delhi Society, executive member of the Association of Gynec Oncologists of India, immediate past president of ISSCP, then master trainer for the MP State Government Screening Program, academic coordinator at the Safdarjung Hospital. She has authored 2 books, many chapters and articles in national and international journals. And I have had the privilege of listening and interacting with Dr. Sarita whenever she has come to Bangalore. We had done the ISCP Congress a few years back, and I had the privilege of listening to her. So, Dr. Sarita, welcome you, and we are eagerly awaiting to listen to your talk.
Thank you so much for the kind introduction, Madam, and thank you, Dr. Asha, for this invitation, and all the faculty who have joined today. Namaskar, Dr. Sharda. It is my this day of Saraswati Puja. This is it's an auspicious occasion for us to have you as a guide here and as an advisor. And Dr. Nirja Batla, respects to you, Madam. Dr. Anita Singh, and Dr. Rajesh, Dr. Sumaya, Dr. Mausmi, Dr. Biba, Dr. Bharat, Dr. Rekha Jha, Dr. Sangamitra, Dr. Rekha Rajendra Kumar, Dr. Pranita, Dr. Jayati, Dr. Indira Palo, Dr. Manoj, Dr. Vanita, Dr. Shiv Kumar, and Dr. Varsha Sinha. Thank you so much, all of you, for being here. So I'm just going to share my screen. Okay. I'll just open it first.
Dr. Kokre, if you would like to say a few words.
No, ma'am.
At the end?
Yeah, sure. Definitely. I can conclude.
Can you see my screen?
Ma'am, it's blank as of now, ma'am.
Okay, one second. Can you see now?
Yeah, now it's visible, ma'am.
Okay.
Yeah.
So the topic for today, postmenopausal bleeding, the assessment and diagnosis. As we all know that, postmenopausal bleeding is becoming so common, maybe because we know that, the lifespan is increasing. And of course, a lot of lifestyle factors like obesity is increasing day by day. So we are seeing this very commonly. So how common is this condition, and what is really the definition? So any bleeding occurring 1 year after menopause is called postmenopausal bleeding. And we see that in 10% of the general population after menopause, 5 to 10% of them may have endometrial cancer. And 95% of the women with carcinoma endometrium present with postmenopausal bleeding. However, we can have, like we were just discussing, 5% of them may not have any bleeding at all. So what are the common pathologies that you find in postmenopausal bleeding? The commonest is a polyp. Second is atrophy. That is the second commonest cause. It can be a proliferative or secretory endometrium in 14.5%, carcinoma in 6.6%, fibroid in 6.2%, hyperplasia without ATPI in 2%, and hyperplasia with ATPI in 0.2%. So these are the different pathologies we can get in a woman who has postmenopausal bleeding. Now, why does atrophic endometritis cause postmenopausal bleeding? It is because, post-menopause, what happens is there is little or no fluid in the endometrium, and that causes friction of the uterine walls and microerosions, and that causes a common chronic inflammatory reaction, and that can cause bleeding. And we can have rare causes like Dr. Shada Jain was saying that, tubercular endometritis, although we see that more commonly in the younger age, but then that could be a cause of postmenopausal bleeding. And cancer of the ovary and fallopian tubes also we find that could be the initial presentation. That could be the only symptom that the woman is having, and on investigation you find that she has an adnexal mass. So that could be the initial presentation. So what are the points that we need to ask in the history? See, what is the amount of bleeding? How much bleeding is she having? Any associated vaginal discharge? So that points to, a cancer of the cervix commonly, because a lot of women with postmenopausal bleeding and discharge, it could be associated with cancer cervix. Any associated pain in the abdomen or back, again, that can point to a cancer cervix, which is already metastasized. And any associated mass abdomen or any distension of abdomen. So is it an adnexal mass which is actually causing the bleeding? And any associated urinary or GI symptoms. So is it really a bleeding coming from the anus or the rectum, or the urinary tract? So they can be associated with urinary symptoms, or if it's a mass that is compressing, then again she could have any urinary or GI symptoms. Any associated anorexia or weight loss. Now, CA endometrium does not really cause any weight loss or anorexia unless it is metastasized, but an ovarian mass, and if it's a CA ovary causing the bleeding, so that could be associated. Any history of trauma, so that could be the cause of the bleeding. And if she's had any fibroid adenomyosis, so that could be, it has now become a polyp, or a PCOS, if she's already had PCOS in the past. So that means she's at high risk for CA endometrium. Any personal history of cancer, if she's had breast cancer, again, she's high risk. And if she's a diabetic, again, that she's a high risk. And if she's had ovulation induction earlier, again, she's a high risk for both ovarian and endometrial cancer. And if she's on medication like tamoxifen and anticoagulants, tamoxifen increases the risk of CA endometrium. If she's on anticoagulants, and then probably, the coagulation has got deranged. Is she on HRT? So these are all the points that we need to ask. And soy and other phytoestrogens actually cause stimulation of the endometrial lining, polyp and leiomyoma growth, and also increase the risk of endometrial hyperplasia. So if it's in high doses, they can cause. Any usage of pessary, if she's had prolapse and she's been using a pessary, again, that could be a cause of bleeding. Any history of radiation therapy to the abdomen, so so that could be a cause. It can increase the risk. And what is her parity? Has she breastfed her children? Any usage of oral contraceptives? Because that again tells you, if there has been a protective effect. And any family member in her family having cancer of the uterus, of the colon, of the breast, all these are important, and of the ovary, because it could be, any of these genetic problems, genetic mutations could be associated with BRCA or with the Lynch syndrome. So what to look for in the examination? It's really important to see the thyroid, breast, and also look for any lymph nodes. 1 second. And the abdomen for any organomegaly. Is there any, is it really an abdominal mass? If there is adnexal mass, an examination of the perineum and the anus, because is it really the bleeding coming from the anal canal, which can be, it can be mistaken for postmenopausal bleeding, or is it a growth in the vulva? So if she's an old lady and she's not even looking at her vulva, or nobody is there to take care of her, so that could be a reason. So there could be a growth sitting there. Speculum examination and pap smear is very, very important, because very often in India, at least, we see a lot of women coming that could be the only symptom they're coming with, postmenopausal bleeding and discharge. And we put in a speculum and see that the cervix it's a full of growth. So that's really an important examination to do, because, you know, if once you say that the lady has postmenopausal bleeding, we just, you know, commonly they just have an ultrasound and that's it. Nobody has a look at the cervix. So please have a look at the cervix and see what, you know, take a pap smear. And pelvic examination to what is the size of the uterus. Is there any adnexal mass that is causing this problem? And what are the initial investigations we should do in a case of postmenopausal bleeding? The first and foremost is an ultrasound, which should be transvaginal, because that can pick up, that can give you the endometrial thickness very clearly, and also look at the adnexal pathology. An endometrial thickness of less than 4 millimeters has more than 99% negative predictive value for endometrial cancer. And this is a meta-analysis, you know, a lot of evidence which says that if the endometrium is less than 4 millimeters, a lot of studies have been done, and they found that negative predictive value is 100%. If it is less than 4 millimeters, the number of women they found was the number of cancers they found with less than 4 millimeters was 2. And then this in 1995, this person found there were 0 cases. So the number of the predictive value is very high. So when do you do? So suppose the endometrium is thin but still the patient has bleeding. So that means that further testing is indicated, and there's recurrent bleeding, and rarely endometrium can have a thin endometrium also. So then going on to endometrial sampling, how is endometrial sampling to be done? So when is it indicated? So any lady who has an endometrial thickness of more than 4 millimeters and somebody who's at a high risk of endometrium, and with even can be a first-line test also with postmenopausal bleeding. So the sampling devices are the Pipel device or the Medgyne endosampler. So we commonly use the Medgyne endosampler in our OPDs, and we find that it's very good. It gives excellent tissue for diagnosis. So if you find any inadequate tissue, or suppose you find that the tissue is inadequate or there is insufficient, what do you do? Sorry. So that can happen in between up to 54% of cases, and there's no further evaluation needed if the bleeding has stopped, and the repeat ultrasound shows a thin endometrium. Then you don't need to do any further evaluation. But if the endometrium is thick or there's persistent bleeding, then hysteroscopic guided biopsy in the OT is needed. Now, we used to do fractional curettage earlier, which was actually taking a biopsy from the cervix, the endocervix, and curating all the walls. And that was useful for diagnosis of endometrial hyperplasia, but it's not very reliable to diagnose focal pathology, and routinely it is not recommended. And can be done. It's useful when the endometrial aspiration is inconclusive. And when do you do a hysteroscopy? So when a blind endometrial biopsy has failed, or you cannot make a diagnosis on that, and to obtain a directed biopsy. So if there is a lesion there and you want to take a directed biopsy, because visualization alone is not accurate for diagnosis of atypical hyperplasia or carcinoma, you need to actually have a tissue diagnosis. And to identify structural lesions like polyps, so they're best seen on hysteroscopy. And where to do the hysteroscopy? So you can offer a choice of anesthesia. Somebody who has comorbidities, we commonly get a PSC clearance. So because, you know, these old ladies could be hypertensive, diabetic, so it's better that, you know, they get the PSC clearance. So suppose they need some analgesia or some sedation, we commonly do it in the daycare setting. So in our minor OT, the patient just walks in and gets it done. But if they have any high risk factors, then we get a PSC clearance and we have the anesthetist on standby. So even an inpatient, we're doing at an inpatient, then the sedation or regional anesthesia is preferred. So what about the pre-op preparation? What about analgesia for hysteroscopy? So routinely use of opiates is avoided because it can cause sedative effects in these old ladies. And NSAIDs can be given before the procedure if it is not contraindicated, so 1 hour before the procedure. Now, should you go for any cervical preparation, it is not to be used routinely, as there is no evidence of benefit. It does not reduce the incidence of cervical or uterine trauma. So the miniature hysteroscopes, which are 2.7 millimeters, the office hysteroscopes are very good, and you don't need much of even dilatation. So just minimal dilatation, or sometimes you don't even need dilatation if it's a Paris lady. So does hysteroscopy increase the risk of dissemination if carcinoma endometrium is suspected? So this is a doubt commonly asked. So what they found is the women who had hysteroscopy and later on they actually had cancer of the endometrium. They found that the positive peritoneal cytology was more common in them, but it did not worsen the prognosis. Now, what do you do if you have an incidental? So as Dr. Nija was just mentioning that case, so what do you do when you have an incidental finding of a thickened endometrium, or you have fluid in the endometrium and the lady is asymptomatic? So the guidelines recommend endometrial sampling is what if the endometrium is more than 11 millimeters, definitely. But if it's between 4 to 11 millimeters, then you can individualize based on what are the high risk factors, anybody in their family having endometrial cancer, or what if she's at high risk because she's obese, diabetic, and she has had long period of PCOS. So all these factors are in high risk, so they should be then evaluated. What about women on HRT? When should they be investigated? So if they are using the estrogen and progesterone regimens, commonly they have some breakthrough bleeding the first 6 months. But if they have irregular bleeding or if they have breakthrough bleeding lasting for more than 6 months, then it should be investigated. Now, what about women on tamoxifen? We do find, a lot of, because a lot of breast cancer is the commonest cancer. A lot of women are on tamoxifen. So what does tamoxifen cause on the endometrium? So earlier we used to do repeatedly, we used to, go for ultrasound and repeated endometrial biopsies. However, because it causes endometrial proliferation, hyperplasia, carcinoma, and sarcomas. So a woman on tamoxifen, if the endometrial thickness is more than 8 millimeters, it is abnormal. However, routine sampling is not effective to detect carcinoma endometrium. It is invasive and is not recommended. But if they have abnormal bleeding or bloody discharge or spotting, staining, in that case, hysteroscopy and biopsy is indicated. So not as a routine, but only if they are symptomatic. So this is actually a flow chart of the approach to postmenopausal bleeding. So the first and foremost, the lady is hemodynamically stable, go for a transvaginal ultrasound. If the endometrial is thin, is less than 4 millimeters, and the bleeding resolves, then we can just keep them and follow up. If the endometrial thickness is less than 4 millimeters, but if it is more than 4 millimeters, or if there's fluid, then we go for endometrial biopsy. And if you can access the endometrial cavity and you get an adequate histological specimen, then you go for appropriate management. And suppose you cannot get a specimen, then in that case, hysteroscopy, and you cannot get an adequate histological specimen, or you're not able to do a biopsy, then hysteroscopy, endometrial sampling, and removal of the target lesion is indicated. So this, so either it can be done so that you can, for the initial investigation can be an ultrasound, or the initial investigation can be even an endometrial biopsy also. So if the histopathology comes as adenocarcinoma of the endometrium, it's very important to ask the pathologist for the histological type, the histological grade, and for any lymph vascular space invasion, and molecular markers if available, because again, whether it's high risk or low risk based on all these factors. And if imaging is needed to know, the MRI is needed to know the depth of invasion, to know the cervical involvement and the lymph node status, because the staging is important to plan the management. So this was actually in last year only the staging was changed, and basically it helped to risk stratify. So now there is inclusion of the histological grade, the LVSI, and also if the molecular markers are available. So anything which is aggressive histology, it becomes high grade, and it becomes high risk actually. So this is how this, if the pole mutation, if the molecular markers are available, that can be done and that could be offered. If it's a pole mutation positive, that means it's a good prognosis. If it's MMRD and NSMP positive, that means that there's intermediate prognosis. It does not alter the stage, but the prognosis becomes intermediate. Whereas if it's P53 positive, then it indicates poor prognosis. So if histologically, if you find that there is P53 positivity, then that means it is high risk and this prognosis, it actually advances the stage. So this is how, if the molecular classification was unknown, then this would be the risk. But if the molecular classification is known, then an intermediate risk, if it is pole positive, becomes low risk. And an intermediate risk, if she's P53 positive, she becomes high risk. So all these, so basically the prognosis changes if you know the molecular, if you have molecular markers. So in conclusion, so any bleeding 12 months after menopause is to be investigated. A good history and a clinical examination are very, very vital to make a diagnosis. Carefully examine the vulva, the anus, cervix, uterus, and adnexa. Transvaginal ultrasound should be the first investigation, and endometrial thickness of more than 4 millimeters. Endometrial sampling is indicated, and hysteroscopy when you suspect structural abnormalities or the tissue is inadequate or there is persistent bleeding. And vaginoscopic method, that is, you don't need to hold the cervix, so you can just distend the vagina and introduce the hysteroscope into the cervix. And isolated DNC should not be used as the first method. And pre-op NSIDs can be used when not contraindicated, and investigate the symptomatic women on tamoxifen and endometrial thickness of more than 11 millimeters and asymptomatic high risk but with an endometrial thickness of more than 4 millimeters, they must be investigated, and any irregular bleeding on HRT, they must be investigated. So I seek your support for the chairperson, Foxy Gynae Oncology Committee of Foxy. So thank you so much for your patient listening.
We request the chairperson to please give their concluding remarks.
Yes, ma'am. A very wonderful talk, and madam has covered the points very nicely. And one more thing, one question I would like to ask ma'am is that if the patient has when we are in investigate, as you said, by doing the endometrial sampling, and the patient is not and it's put to be not malignant, but after how long the follow-up should be taken for the second time? Like, what should be the duration of the re-examinations?
Yes, you're saying you did an endometrial biopsy and it is normal.
Yeah.
Okay, so I actually didn't touch the management at all because Nisha is going to cover the management. So
when should come back, and after how many days she should be re-evaluated?
Yeah. So if the symptoms have subsided.
Yeah.
Right now, if she has no symptoms at all, then you need not, call her. But if she has persistent symptoms, then definitely in 6 months, I would review her.
Okay. Thank you, ma'am. Very nicely elaborated.
Thank you.
Are there any questions?
Yeah, I would like to congratulate Dr. Sarita for the wonderful, implicit and very comprehensive talk. I think she has rightly emphasized the importance of history taking and clinical examination, apart from other investigating modalities. And she's also updated us about the guidelines. Wonderful talk, ma'am. I also thank Dr. Jain for this webinar and for providing us an opportunity to take part in this webinar. Thank you.
Thank you, ma'am.
Thank you so much. And
am I allowed to ask
Dr. Shubha ma'am wants to add something. I think ma'am wants to.
can I just add something?
Yeah,
the thing was, of course, Dr. Sarita, your talk was very excellent, and told us very lucidly as to what we must do when a proper history taking and a proper examination. And nowadays, histopathology is not just histopathology, but there are so many markers which will tell you, what is the prognosis. Very important there. And of course, going back to the question where Madam Sharda Jain was saying, if there are repeated episodes of bleeding and, you have done HP, which is negative, we always recommend, okay, I mean, a postmenopausal bleeding, we would recommend removal of the uterus. But that stubborn patient who doesn't want, I think we must at least put an LNG device, because that is, the treatment for most of the problems. Even if there's hyperplasia or early cancer, it is going to be of help. So I think an LNG device should be inserted if the patient is not willing to undergo surgery.
Yes, definitely. Yes.
Dr.
Because,
Sarita, may I ask a question?
yes, ma'am. Yes, Dr. Asha, please.
See, actually, hysteroscopy, everybody says hysteroscopy, but there is evidence that hysteroscopy means, I'm asking you that hysteroscopy, will it cause spread of the disease?
No,
If
no.
there is endometrial cells, what should be the interval between a hysteroscopy and a definitive surgery? If preoperative, you are expecting a malignancy, would you still do a hysteroscopy? And if you are doing a hysteroscopy, what are the chances of spillage?
Yeah, so you can, so if there is a case of, I already mentioned that in the slide. So if you do hysteroscopy and you find that endometrial cancer is there, the histology, so you will find positive peritoneal cytology in them. But that doesn't increase the stage, it doesn't increase the prognosis, it doesn't worsen the prognosis.
But many a times, because the cornual end of the tubes are going to be blocked in the postmenopausal women, I think, I mean, because of the atrophic changes that have happened, probably the spillage is less and we must not use too much pressures while doing hysteroscopy.
Yes, so yes, should do under low pressure, but they have found, many studies, they have followed up patients and they found that it does not increase the stage, it doesn't worsen the prognosis. And in fact, although it is done routinely for staging the peritoneal cytology, but it does not, it does not factor in the staging of the CA endometrium. So you may find positive peritoneal cytology.
And Dr. Sarita, may I add one point, practical point here? Dr.
Yes.
Rekha here.
Yes.
Dr. Asha Jain, with your permission.
Yes, please, ma'am, please go ahead.
Yeah, only one point. As you were talking about the hysteroscopy, one has to be very careful in this hysteroscopy, though it's a very small diameter. Very small diameter. In spite of that,
Dr.
because
Rekha,
of the combination of,
Dr. Anita has joined in. She's our guest of honor and she had not joined in before. So, namaste, ma'am.
Good evening, Asha.
Good evening, ma'am.
Good
If you
evening,
don't mind,
everyone.
Dr. Rekha, take your question later. We'll have blessings from ma'am first.
Yeah.
Yeah,
Proceed,
we
no
will.
problem.
Should I start talking?
Yes,
ma'am,
madam.
please.
Okay. So, dear Asa, dear Sarita, Rekha, and everyone, whoever is there, I'm so sorry. First of all, I want to apologize for the delay that I have joined. Your program was so well chosen, full of so well chosen topics. I really wanted to attend the whole program, but somehow or other I got delayed as usual with the obstetric patient. So now I have joined. So I think I missed Dr. Sarita's talk, and I hope that this program is going very well, and we have got a large number of listeners to this program, and I wish good luck to Asha and Sarita and in the future, and I'm there with you. Thank you very much for calling for this program, and I wish all the success for this wonderful program that is going on. Thank you very much and keep in touch with me. Okay.
Thank you, ma'am. Thank you. Thanks a lot for joining in, even if it's late. And I can share the recording so you'll not miss Dr. Sarita's lecture.
Okay. That will be very good on your part.
Thank you, ma'am. So, Dr. Rekha, you may take over.
Yeah, just had to add to what Dr. Sarita and Dr. Shubha were telling regarding his diagnostic hysteroscopy, though it's a very small diameter, 3 mm, 5 mm hysteroscopy use. One, the cervix will be very tight because the postmenopausal, the internal loss. So you have to be very careful when you negotiate. And second thing, the uterine cavity length will be very small.
Yes.
And third thing, the musculature will be very much atrophic. So because of all these 3 points, one has to be extremely careful regarding the perforation which can happen. for the juniors to know, that's all.
Absolutely, yes, yes. That's why the thinnest hysteroscope.
Thank you so
Yes.
much.
Thank
We
you.
today have exceeded our time. Thank you, Dr. Sarita. That was so good.
Thank you. Thank you.
May we have the CBs of the second talk, please? Because
we're running a little late, so we'll proceed with the second talk. The chairpersons for the second talk are Dr. Masumi Dev Banerjee, ma'am. She's the consultant obstetrician and gynecologist from Calcutta. She's the president of the Bengal Obstetric and Gynecological Society, vice president, IMA Calcutta branch. She has organized Boxin, Fetocon, Endogyne, numerous conferences. She's also been the member of the organizing committee of AICOG 2007, which was held in Calcutta. Ma'am has been an orator in various eminent talks. She's participated as a faculty in various national and international conferences, published papers. So we're very happy to have you here with us, ma'am, today. Next, I would like to introduce Dr. Biba Chowdhury. Ma'am is director of Tapasvi Multispecialty Hospital and Baby Boon IVF Center, Bhagalpur, Bihar. She has been practicing obstetrics and gynecology for the last 41 years, and she has been practicing infertility since 2010. She's the in-charge medical officer, Department of Preventive Social Medicine, Jawaharlal Nehru Medical College, Bhagalpur. She's also the president of Bhagalpur OB-GYN Society. So, madam, it's an honor to have you with us today. I would also like to introduce the next chairperson, Dr. Bharat Lanjewar. Sir is the consultant at Sahyog Hospital and Test Tube Baby Center, which is the first center in Bandra. He's also the president of OB-GYN Society, Bandra, and president of IMA Bandra. He's been practicing since 35 years. He's the founder secretary of that society, and sir has special interest in managing high-risk pregnancy, infertility patients, and he also conducts various medical awareness programs. I don't think sir has joined in. I request the chairperson to please introduce the speaker of this session, Dr. Nisha Singh.
I just wish to correct, it is Bhandara, Maharashtra.
Noted, ma'am.
Over to you, respected chairpersons.
May I introduce the speaker?
Ma'am, please go ahead, ma'am, please.
Hello. Okay. At the onset, I must thank Dr. Asha Jain for giving the Bengal Obstetric Gynecological Society this platform and involving the president as well as the secretary as the faculty. So it's a very proud opportunity to be amongst the galaxy of eminent personalities here. So now the speaker is Professor Nisha Jain. She is the unit head and in charge of the Genital Cancer Control Unit, King George's Medical University, Lucknow, India. Vice President of Association of Gynae-Oncologists of India, Vice President of Lucknow Obstetric Gynecological Society, and that of UP State Chapter of AGOI. She is a Joint Secretary of Asia or Oceania Research Organization on Genital Infections and Neoplasia, member FOXI HIV/AIDS Committee, and started the Hereditary Gynae Cancer Clinic at AGNU. She has a wide experience and written many chapters and has many publications. And she has also received a number of awards that are here. So we are over to you, madam, for your session.
Thank you so much, Dr. Mashmi. And as I just share my screen, I would like to thank the organizers, Dr. Asha, of course, who has been very kind to invite me here. And I pay my respect to Dr. Sharda Jain, Dr. Nirja Batla, who has also been my mentor during my post-graduation, and of course, Dr. Anita, and all the presidents and secretaries from different societies. Without wasting much time, I'll start the talk. And since Dr. Sarita has set the stage already regarding the investigations that needs to be done, how do you do the workup for, just a second. Yeah. So I'll be talking about the management of postmenopausal bleeding. And as I start, it will be basically just the causes that are known, some of the rare ones. What is the overview of the management and the management outline for each particular cause? I'll be trying to deal with them. As we have heard that the important causes are senile endometritis, which is one of the common causes, though a diagnosis of exclusion actually. Endometrial polyps, endometrial hyperplasia, CA endometrium are the conditions which are the structural causes. Fibroids and adenomyosis, though less common in postmenopausal women because they usually will present in the perimenopause. Apart from that, CA cervix must be ruled out, and tubercular endometritis, and very, very rarely the CA ovary and fallopian tube carcinoma may also present with postmenopausal bleeding, particularly the hormone secreting tumors if they are there in the ovary. So important points in the evaluation are that we have to take a good history, do a thorough examination, and remember that normal size of uterus, which we say for reproductive women, is not normal in postmenopausal women. So anything which is more than atrophic is abnormal. And endometrial thickness we have talked about. There was a word on hysteroscopy. So biopsy is better with hysteroscopy, particularly if the endometrium is irregular. It's thickened and it is irregular or has a focal lesion. In those conditions, we should go ahead for hysteroscopy. Otherwise, we can do away with the endometrial aspiration. Cervical cancer screening should be added if you don't find a lesion, and add ECC also to rule out, sometimes we miss on an endocervical carcinoma also. So talking about the endometrial polyps, first of all, that are suspected if the ET is, say, more than 12 to 15 mm. I usually tell that if it is so much, then even if it is looking like a thickened ET, there might be, which could be confirmed by either adding a color Doppler or doing a sonosalpingography. But if you take this woman directly for hysteroscopy, it will be the best choice, because not only for diagnosis, but even for therapy, because you can remove it simultaneously in the same sitting. So that is how the endometrial polyps are to be. This is just a small thing, if you can see, regarding the so there is this polyp, you just hold them. These mucosal polyps, you can see another one also, and then they can be just pulled out and managed like that. So this is one of the algorithms. Of course, in the reproductive women, you will find them more often, and there it will always be a conservative approach. In postmenopausal women also, in the first go, if it is a solitary or even 2 or 3, you can remove. But if it is whole of it is a polypoidal endometrium, then you take an endometrial aspiration, because you can't remove all of them, and you send it for histopath. And if it just comes like that, then here LNG-IUS may also work. Later on, you can put that. But if there is some abnormality, which we'll be talking about, of course, we have to take another action. Coming to the leiomyomas or the fibroids, if you find during the evaluation in the ultrasound that there is a fibroid, because usually in postmenopausal women, mostly they will not be very big fibroids, they may be the submucous ones. And we know this FIGO classification that of late is very commonly used in the practice, where the submucous are the type 1, 2, and 0, 1, and 2. And then you have the one which is just contacting the endometrium, but 100% intramural, also to be treated like, because the effects will similarly. So depending upon the site of the fibroids and also the number, you will have to take a decision, the call on what will be the management. Small submucous fibroids may be treated with LNG-IUS also. Otherwise, bigger ones will need a surgical management. Solitary so distinguishing the myomas that involve the endometrial cavity from the others is important, because that will help you guide what management protocols should you use. And as I said, if they are appearing on ultrasound submucous, then hysteroscopy will be both confirming. And if you do hysteroscopic myomectomy, it can be treated simultaneously also. If it is a solitary myoma and it is submucous, or even if it is intramural subserous, if the patient wants a uterine conservation, it may be done after counseling her that if she has one, there may be more that may come up. But if she wants to preserve, if it is solitary, it can be done myomectomy also for them. But if there are multiple and involving the different parts, then obviously one has to go for a hysterectomy, not like the reproductive age group, where even in those we would like to give, if the fertility is an issue, we would like to do a myomectomy. So here in postmenopausal women, multiple fibroids, mostly it may be of course, if there are very small submucous, this one I just added just to show you that sometimes the cavity may be filled up like this, and then you have, but this one also was removed because it was a reproductive young woman, but in a postmenopausal, of course, we will be doing so this is the case that we just removed it all hysteroscopically. So in postmenopausal women, multiple fibroids, you can offer her hysterectomy if she agrees to that. So this is that algorithm where nothing much to be told for women more than 40 and not desirous of fertility, as I have said before. Coming to adenomyosis, which sometimes may be a presenting cause for postmenopausal bleeding. And nowadays we have a lot of newer criteria. The MUSA group that has defined some criteria for diagnosis of adenomyosis, these 8 asymmetrical myometrial thickenings, myometrial cysts, hyperechoic islands, fan-shaped shadowing. So all these may be helpful in diagnosis. And this will come up when the uterine size is, just slightly enlarged. Endometrial biopsy is normal. And as we were talking that in those cases, the bleeding continues. So maybe it is an adenomyosis, which, only if a good scanning has been done and has been picked up. So that's why it may help in that. And where also I heard, as somebody said, LNG-IUS may work. So yes, even for adenomyosis, if there is a woman who doesn't want it to be removed and everything otherwise is normal, you may put that. So treatment, as I have said, but endometrial aspiration is must, even if you are seeing these structural lesions in a postmenopausal women. That is what needs to be added to the management approach. Hysterectomy, of course, approach could be open or MIS, whatever one does. Now coming to endometrial hyperplasia. As we all know, the recent WHO 2014 classification, now simply we have hyperplasia without atypia and with atypia. Why two just have been made? Because of the prognosis, because of the possibility of progression to invasive CA, and also chances of coexistent. So with hyperplasia without atypia, there is only 1% chance, less than 1%, that there is coexistent C endometrium, and the risk of progression is 1 to 1. The relative risk is just 1.0, 1.0. With atypia, coexistent C endometrium may be there, which is 25 to 33%, and the relative risk of progression is also 14 to 45. So this category definitely needs to be treated. A definite treatment should be done. Hysterectomy is required in these cases. While hyperplasia without atypia, if you find, you may put in an LNG-IUS for that also. So surgical treatment definitely for endometrial hyperplasia with atypia. And the histopath later also of the uterus has to be followed, because as I said, coexistent may be there in some cases. So that is important. Women may also be for the hyperplasia without atypia. Apart from LNG-IUS, progesterone therapy may also be given, but then you need to follow them up later with that. So that is the algorithm for the AUBM, that is your hyperplasia and malignancy. Malignancy particularly, I'll be talking now a little bit in detail, not too much, because we got a panel on that. So this is how the pictures, and Dr. Rekha was telling that you have to be careful because of the vascularity, and because, so these are the pictures. If you get something like that, then you have to think that it is definitely, although on scanning also nowadays with good ultrasounds, it will be apparent. So the recent changes in the CA endometrium staging and has affected the management also. We know that the molecular classification has been incorporated. We have stages separated for aggressive and non-aggressive histology. And so upstaging or downstaging of the disease may be there depending upon the type of histology and also the grade of the tumor. And then the management will also be affected. Grossly telling, after you know that the endometrial biopsy, you know the type, you know the grade, and if possible, you know the molecular profiling also, you can tailor your surgery depending upon what is the age of the patient or the fertility and all those things. But the standard treatment once is a Maudlin vertical incision, peritoneal washings, thorough exploration, and doing a extrafacial hysterectomy with bilateral salpingo-oophorectomy with or without lymphadenectomy. How we decide on lymphadenectomy, I'll be just coming in the next slide. So, but the concept that needs to, I just want to highlight that previously, as they used to say, that if it is a cervical involvement, you do a radical hysterectomy, that is take out the parametrium and all, is not recommended for CA endometrium. Omentectomy will be required in cases of papillary serous cancer. So serous is the worst prognosis one. So if that is there, or you have P53 already there, then omentectomy should be done in those cases. About the lymph nodes removal, if the tumor is more than 2 centimeter, if the tumor is involving outer half of myometrium, if it is moderately or poorly differentiated disease, that is grade 2 or 3, if it is an aggressive type of histology, if there is cervical or adnexal involvement, if there are already enlarged paraaortic or pelvic lymph nodes. So in all these conditions, there will be a need to go for the lymph node removal. Of course, we start from the pelvic first, that is from the common iliac up to the obturator. And if there are enlarged ones, then only the paraaortic have to be added. So nowadays, you have to decide about this preoperatively based on your MRI and on your histology of the endometrial biopsy. And even the adjuvant therapy will be needed depending upon what we get as the final histopathology. Depending upon the risk stratification, you have to decide the adjuvant therapy, and also the molecular classification will help here also, because the prognosis will be affected by that. So if we have those answers, we'll be managing the doing the adjuvant therapy according to that. Management of acute bleeding. If a patient comes and, sometimes they have bled so much and they are in shock, then the shock management has to be done on priority. Patient has to be stabilized, and medically for stopping the bleeding, we will use tranexamic acid in the initial phase, or sometimes high dose OCPs. These things are more useful in the reproductive age women. Usually postmenopausal women do not come with such heavy episodes of bleeding, but once in a while we may get such patients, and you must rule out some kind of coagulopathies and all those conditions also, which may rarely be there. So that is about the AUBC, which also could be. Then we were talking about the genitourinary atrophy, the hypoestrogenic changes that occur in menopause, which cause atrophy of endometrium and vagina and lead to bleeding, the breakthrough bleeding. The mechanism already told by Dr. Sarita. And it is a diagnosis of exclusion, because you do a complete evaluation. When you don't find anything which is malignant or pre-malignant or structural, and then this is what. But when you examine, then also you see that how are the vaginal rugosities, at least vaginal atrophy can be seen. But of course, endometrial atrophy only either on hysteroscopy or as a diagnosis of exclusion will be there. So bleeding usually is self-limited and requires no treatment in these conditions. But if vaginal dryness, if it is there, it may be treated with non-hormonal vaginal moisturizers and lubricants to maintain the sexual activity, or estrogen, topical estrogen can also be used for the vaginal atrophy. And as we use the hormone replacement therapy, particularly if patient has systemic therapy may be given if she has other features of postmenopause, also menopausal symptoms also. So sometimes infection may be the cause of the bleeding. So if there is sexually transmitted disease, so you do those swabs, or if you clearly see that there is candidial infection or some other, you have to treat it accordingly, which sometimes may be associated with some bleeding. Then there are some medications which also could be the cause, and you have to identify them by the history and take adequate action. So hormone replacement therapy frequently causes PMV for the first 2 to 3 months after the initiation, and that also resolves. So here only counseling is required for the patients. For anticoagulants leading to vaginal bleeding, progesterone therapy may improve the bleeding until anticoagulants can be discontinued. And long-term solutions will be needed for patients who are on lifelong anticoagulation. So sometimes they bleed, and then a hysterectomy may be required just because you cannot manage that, stopping that anticoagulant therapy. Rare conditions, tubercular endometritis, yes, we find it more often in reproductive women. Many women, we do endometrial biopsy and granulomas, and these are indicative, and we treat them with ATT. CA ovary or fallopian tube, of course, if that is diagnosed, I mean, if there is an adnexal mass simultaneously, then of course it will be treated like with the staging laparotomy as indicated. Some less common DDs, sometimes patient comes, I mean, this is really basic, but patient comes and says she's bleeding. You must rule out it's not a hematuria, which may be due to genitourinary atrophy, because risk of urinary malignancy is very, very low. But then if somebody is coming, so we must, and also sometimes women may come and it is a gastrointestinal bleeding. So that is also important through history and examination to be very sure that it is a vaginal bleeding only and nothing is simultaneously present, the other conditions. So to summarize, a stepwise evaluation is important. A complete diagnostic workup is important. And as per the specific diagnosis, that is a precision diagnosis, and we have to treat. If it is an unexplained bleeding, which mostly will be the genitourinary atrophy, if so, close follow-up, and if she has symptoms again, then she should be reevaluated. Dr. Sarita said 6 months. I would say, like, whenever she comes, if comes with an abnormal, with a repeat episode, of course, at that time, but otherwise we may call her back in 3 months and maybe we can see the endometrial thickness once again. So, I mean, that is not something written somewhere, but then probably we feel within 3 to 6 months, we should reevaluate. Thank you so much.
Thank you, madam, for your wonderful lecture covering everything in a short and crisp way. And but I have a question to you. It becomes very challenging when the patient takes a anticoagulant for a long time and comes with a postmenopausal bleeding with repeated episode and a moderate amount of bleeding. So then, what is your take?
Yeah, that is what I said, that initially, I mean, how much, whether you can stop the anticoagulant, it has to be, communicated. We have to discuss with the physician who's taking care of whatever is the condition and all. And if it cannot be, for a short term, you can use progesterones, it may stop. But then if it is, repeated episodes and we cannot, it is a long term, then maybe she will have to go for that, for a hysterectomy, because it is a postmenopausal woman. That's what I said. Anything else?
I request Dr.
Thank you.
Biba Chowdhury to also offer her concluding remarks. Ma'am, would you like to add something?
I would say, regarding the anticoagulants, actually the dose needs to be reevaluated. Probably the dose, if it is causing bleeding, that could be, that may be the cause. The anticoagulant could be the cause of the bleeding. So they could, they review stopping it and maybe consider changing the anticoagulant. Yeah.
Thank you so much. We've had excellent speakers, and I feel very happy to see that today knowledge that will help the normal obstetrician gynecologist sitting in the OPD to help their patients better has been shared. And Dr. Nisha, you actually did it in 20 minutes. So hats off to you. You covered everything. Even Dr. Sarita didn't take much time, but you asked me and I said that it has to be basically a flow that gynecologists can understand and follow. So thanks a lot for that. Nirja ma'am, any comments from you?
I think they're both excellent talks, and they've been so precise and they covered it so nicely. And I think that they have left no room for any doubt. Well done.
Thank you, Dr. Nisha.
So I think I thank all the chairpersons and the speakers for conducting this part of the session. And now we will be testing ourselves to know how much we've actually retained. So we'll take the panel, and in the panel, we'll see how much we have retained in whatever is going on.
Mehul, could you please share the slides?
Mehul ji. Yeah. So we have this panel, and the topic is cases of postmenopausal bleeding, highlighting the management as per guidelines. We have two experts, Dr. Rekha Jha ma'am and Dr. Sanghamitra Mahapatra ma'am. May I have their CVs? So Dr. Rekha Jha ma'am, I've known her for some years now. She's the past president of Bhagalpur Obstetric Gynec Society, was a great host at the Critical Care Foxy Conference in Bhagalpur recently. So she has got the credit of getting D.K. Tank Award for Society as president. She is the scientific chairperson of IMA Bhagalpur, was the secretary of IMA Bhagalpur in 2003, RCH coordinator 1997. More than all of this, she is happy to be there and work for the society and also help us whenever we need her for any program. So welcome, Rekha ma'am.
Thank you, Asha. Thank you so much.
Next, please. We also have Dr. Sanghamitra Mahapatra ma'am, who's the professor and HOD, MKCG Medical College, Berhampur. She's a member of ISOPAP, Foxy, IMA, ISAR, and BOX. She has many publications in national and international journals. She is working as professor and she is currently the president of Berhampur Obstetric Gynec Society. Her special interests are high-risk pregnancy, infertility, and laparoscopy. We have...
Thank you, ma'am.
Panelists. Welcome, ma'am. So these are two experts and these are our panelists who are no less expert, but you have to actually name somebody as something. So we have Dr. Rekha Rajendra Kumar, who's the president-elect Bangalore Society, Dr. Pranita Ajay ma'am, who's the secretary of Bellary Society, Dr. Jaita Chakrabarti, who's the secretary of Bengal Obstetric Gynec Society, Dr. Indira Palo, who's the secretary of Berhampur Society and a really dear friend, and she's always been there. When I did the state conference in Raipur, she agreed to conduct a panel, and that was her actually first exposure. She's always been there for me. Dr. Varsha Sinha, who's the new secretary of Bhagalpur Obstetric Gynec Society, Dr. Manoj Aglave, who's the secretary of Bhandara Society, Dr. Vanita Medgod, who's the president of Belgavi Menopause Society. She has kindly agreed to be here, and Dr. Shiv Kumar Etsi, who's the president of Bellary Society and may not be able to join because of some emergency. So with this, I welcome all the panelists and the experts, and we will start the panel proper. Something gone wrong. Yeah. So we have Bangalore, Baramati, Belgaum, Bellary, Bengal, Berhampur, Bhagalpur, and Bhandara Obstetric Society with us. Dr. Sujayshri Sangeeta is our... I think this is the wrong presentation. So once again, we Say pranams to Ma Saraswati. Saraswati namastubhyam varde kamarupini. Vidyarambham karishyami siddhir bhavatu me sada. So first, as an introduction, this has been covered by Dr. Sarita. What are the causes of bleeding? Polyps, hyperplasia, carcinoma, exogenous estrogens, atrophic endometritis, vaginitis, and other causes. What is the relative risk of endometrial cancer? If it's nulliparity, 2 to 3. Late menopause, more than 52 years, 2.4. Obesity, 15 to 25 kg overweight, 3. More than 25 kg, 10. Diabetes, 2.8. Unopposed estrogen therapy, 4 to 8. Tamoxifen, 2 to 3. And atypical endometrial hyperplasia, age to 29 times is the risk. So, Dr. Indira, have you named yourself something else? You are muted. Please unmute yourself and please name yourself correctly. I recognize you, but you need to rename yourself. So, this is the flowchart that Dr. Nisha has explained beautifully, that you have an abnormal reading, you do an office endometrial biopsy, it's unsatisfactory, abnormal, negative with confused symptoms or negative with no symptoms, and how you're going to follow it up. So the basic thing is you need to take a biopsy. And this is the management depending on the cause. So this is one chart that covers everything. The most important thing is the atrophy, then without atypia, with atypia, leiomyoma, polyps, and cervical polyps. So now we come to the first case. There's a 59-year-old lady, postmenopausal by 6 years, reported in the OPD with postmenopausal spotting off and on for 2 months. On examination, she had a lemon-sized polyp hanging from the external os. It was removed and sent for histopathology. The report was benign endocervical polyp. Okay, so far, what was done, was it right or wrong? Please unmute yourself, respected panelists and experts.
Yeah, can I
Anyone
take
can
the question?
Yeah, anyone.
Yes,
anyone.
ma'am.
Anyway.
Yeah,
Okay.
thank you.
This was her age is 59 and she has a postmenopausal bleeding, and when the cervical polyp was seen and only that was removed, and they have not tackled about the endometrial cavity, because these polyps are also associated with endometrial polyps, and also we should know the root of that polyp, origin of the polyp. And at least endometrial biopsy or hysteroscopy was advisable.
Exactly.
She should be properly evaluated before going for the biopsy.
See, on her ultrasound, it was a 2 mm endometrium. So they just did that removal and sent her off. Okay. Now, 3 months later, she presented in the OPD again. There was persistent spotting for 3 months. Now, transvaginal ultrasound, hysteroscopy, and biopsy was done. Histopathology showed grade 2 endometrioid adenocarcinoma. So, what is the take home in this case? Means I want one by one everyone to speak on it. Dr. Rekha, yes?
Yeah, thank you, Dr. Asha. As it was a very glaring thing with the combination of a very thin endometrium plus a glaring polyp there sitting right, the doctor has done the polypectomy and sent for histopathology also. But though he is partly right, but there are certain things which were not covered completely. Especially, this is a case where it can really become a medico-legal issue. Patient has come back in very close time, that is immediately soon after the procedure. Within 3 months, she has come back to us, and that too ultimately got the diagnosis of endometrioid adenocarcinoma on top of that. So the doctor should have been more careful in assessing not only the what is glaring at us, but make sure and try to do the analysis of rest of the organs and evaluation by investigations like as Dr. Sarita and Dr. Nisha were telling, the endometrial sampling, etc., so that you are very sure that nothing is there in the endometrium, and also the clear evaluation of the other pelvic organs like the ovary and rest of the abdomen.
Dr. Indira?
Even if there is an obvious pathology is there, but you have to complete your evaluation in the same sitting, first sitting also. Because the polyp is a hyperestrogenic state. In a case of a postmenopausal woman, when you are getting a polyp, that indirectly points that there is a state of hyperestrogenism. So you have to look, so you should have looked the estrogen. Many times the ultrasound report may not give you a correct, if it is not done transvaginal, you may miss a endometrial thickness properly. If it is not a gynecologist, they may not give such importance to endometrial thickness. So it is indirectly it shows that it is a hyperestrogenic state. So in same sitting, we should do it properly.
Agreed. Sanghamitra ma'am, anything to add?
I would like the
So the take-home message is you have to go for the assessment of the endometrium with tissue pathology, even if there is a benign cause. So that is the take-home message.
Dr. Rekha ma'am would want to add something.
So, you know, any of the postmenopausal bleeding should be histopathology should be done, because 5 to 10% may be having carcinoma. It should not be overlooked in any of the case, because most of the endometrial carcinomas, they show up with postmenopausal bleeding. So since 5 to 10% of them will be having carcinoma, it cannot be overlooked, and we cannot in this age think of it as a benign thing. So even if the histopathology of the polyp was benign, at the same sitting, the histopathology of the endometrium should have been done, because this is showing that hyperplasia was there. Somehow there is a polyp. So you have to go for the histopathology of the endometrium as well.
So that is where everybody agrees that this is what was missed was the initial evaluation of the endometrium, as initially pointed out by Dr. Vanita. So the take home here would be that even if something looks benign, don't take it to be benign. Only this can be responsible. Could be something else. Now this is case number 2. Mrs. S, 48 years old, had CA breast, right MRM was done, chemo was given. CA breast was ERPR positive, HER2 neu negative. She was given tamoxifen and advised yearly transvaginal ultrasound. She has been amenorrheic for the last 4 years. So what is happening is that she had cancer 3 years back, but before that only she had become amenorrheic. Now she has some discharge and scanty bleeding. A routine transvaginal scan shows a thick endometrium with irregular cystic spaces, looking like an 18 mm endometrium. There is no midline echo, no free fluid in the cavity. There is a grade 2 flow, and the endomyometrial junction is well maintained. It's well maintained. So what is the differential diagnosis? What could it be? Yes, Dr. Varsha?
The patient. Yeah, thank you, ma'am, for offering me this question. Like the differential diagnosis goes that she was on treatment with tamoxifen, so it cannot be overlooked. We have to think over it, then we have to plan our action accordingly. So there might be underlying endometrial pathology because the endometrium was very thick. So it needs to be evaluated, and accordingly, we have to consider because it is of tamoxifen or some endometrial pathology is still underlying. So, so accordingly, we have to differentiate since the endometrial thickness, according to the ultrasound, was very much thick. So it needs consideration. And what is the Doppler flow? Doppler flow is also important.
What is the differential diagnosis? What all do you think it could be?
Ma'am, it could be endometrial hyperplasia. It could be endometrial carcinoma also. We cannot rule out at this early stage, but we can think it as a differential diagnosis. Might be endometrial polyps also, because in a postmenopausal women with such thick endometrium, it cannot be ruled out. So these are the possibilities that we look upon. So we have to differentiate among these four criteria.
Okay, so now what is the plan of action?
So, ma'am, we can offer endometrial biopsy either on an outdoor procedure, or we can go for a hysteroscopic management. We'll do a diagnostic hysteroscopy. Then, depending upon how the picture is, we can take a biopsy easily from the hysteroscope, and we can wait for the biopsy reports as it says.
Dr. Pranita?
So according to the...
Yes, ma'am. Would you do a hysteroscopy? What
Yes, ma'am.
are the guidelines about it? You want to do a conventional hysteroscopy or you want to do an office hysteroscopy?
If the patient is associated with high risk factors, comorbidities, then we may have to take her up in the OT with regional anesthesia. But if she is not with a high risk other cofactors, then we can go for office hysteroscopy. But in this case, I feel it is endometrial thickness is too high. It is 18 mm. I'll go for a proper hysteroscopy in OT with the good anesthetic cover-up.
Okay. So how would you've done a hysteroscopy and you haven't really seen anything, and how would you like to take the biopsy? By pipette, by suction, or by curettage?
I'll prefer by endometrial biopsy by suction. I'll take, ma'am. But the hysteroscopy...
Dr. Vanita, you want to say something?
No. It's a people's biopsy is just a diagnostic procedure which is not advisable here, and suction is also not advisable. I feel a hysteroscopic directed curettage is important. It covers, because a bland DNC, it misses 50% of the lesions. Like if the lesion covers more than 50%, then only it comes positive. So hysteroscopic directed curettage is I advise.
Anybody has some other opinion? Yes, Dr. Indra?
Yeah, please, Dr. Indra.
Actually, tamoxifen-induced hyperplasia mostly causes subendometrial hyperplasia. It is a selective estrogen receptor modulator. It acts as anti-estrogenic in breast, but it acts as a estrogenic in the endometrium. But it does not actually causes endometrial hyperplasia. It causes below the endometrium subendometrial hyperplasia or cystic changes. So you need a curettage. Many times, many persons do not have a hysteroscope with them. So it is better to go for a curettage with some pressure. Then only you will get some sample. You may not get any sample if you do a suction only or pipette only, if it is a case due to tamoxifen-induced hyperplasia. Because tamoxifen-induced hyperplasia is different from the estrogenic hyperplasia that usually you get. It causes below the, as madam has said, endometrial junction has been preserved, and below that junction it causes cystic hyperplasia. So you need a deep curettage.
So then you have done a curettage is done. You sent it for histopathology. Do you also wanted to send it for any tumor marker or IHC?
Definitely, because she is a case of breast cancer, and she is ER positive and PR positive, HER2 negative was there. So definitely she is a cancer survivor. We will go for the, what is your ER PR markers? We should go for that.
So now what actually happened? When you did a hysteroscope, you didn't see anything significant.
Yes.
Very scanty tissue was obtained on biopsy. The histopathology showed atrophic endometritis. Slides were reviewed at 3 different places. Same diagnosis, that it is atrophic. Then what is the explanation of the thick cystic endometrium on transvaginal scan? How do you explain that?
Would Dr. Rekha like to answer, madam?
I would like to answer, but I'm not very sure of my explanation. This has happened to me also in my practice. That it
has happened to everyone, and that is why I put this up. That why does this happen? What is the explanation?
exactly.
I'll
Probably.
give you a clue. The answer is in the first sentence I spoke about this case. Okay, now come on, let's proceed.
Yeah, let's give Dr. Rekha.
I'm not very sure, but probably it is the interface of the endometrium that we are not very sure or clear and all that. It has happened when I myself have scanned the patient also. The endometrium looks like that, cystic or not cystic, but looks really thick. And maybe because of the interface between the endomyometrial junction and all that. But when you do a biopsy or hysteroscopy, there is hardly anything what you see. I don't have the explanation for this. If anybody can tell me on this, I would be happy.
Tamoxifen. Actually, tamoxifen
not
produces a typical histological cystic spaces. Tamoxifen produces this. There
Not
is
only
atrophy of the
tamoxifen,
endometrium, but there are cystic spaces seen. That's very typical of tamoxifen, and on hysteroscopy it can be seen.
No, without
Dr. Sanghamitra?
I have seen that.
Yeah. Now, tamoxifen causes a unique picture in ultrasound.
Yes.
It causes cystic glandular dilatation and stromal edema. And that may be responsible for the typical picture.
Yes.
But what Dr. Rekha is trying to say is, even the absence of
Ma'am, the
tamoxifen,
question
madam has
is that
noticed it.
all that was there, but then why no tissue? We did the hysteroscopy, it was normal. And then very scanty tissue was obtained and it was atrophic. Nothing else.
Yes,
it was just atrophic.
The typical ultrasound picture, which was echogenic endometrium, thick echogenic endometrium, is due to cystic glandular dilatations and stromal edema. So you might not have got that by report.
Okay, so what I understand it basically is that she had menopause. Means this is another guess that I'm putting forward. Any guess is good here, but this is what we all face at some time or the other. That she was amenorrheic before she got that breast cancer. Then she had that chemotherapy. Then she had tamoxifen was started. In between, she had radiation. So what has happened is she has developed adhesions inside her uterus. So there is a little bit of trapping of tissue over there, and it's like in Asherman's you'll see. But in Asherman's you don't see the EMJ. Here you are seeing the EMJ because it's not abnormal. But both walls of the uterus have stuck together. And it gives a very weird, different appearance.
What I was trying to explain is, of course, I take your point, Dr. Asha. Even if the patient is not on tamoxifen, we have seen such cases. The discrepancy between the ultrasound picture and the histopathology, I mean the hysteroscopy or the biopsy, you hardly get any material, where then you will go stick with the latter part. Like there is a scanty endometrium and histopathology is nothing, and you are happy that way. You take the latter point and stick on to that.
Dr. Sarita like to add something, ma'am. Would you like to throw some light on this point? Dr. Sarita, is she still with us?
Yeah, actually, I missed some parts of it because my network was poor. But if you can repeat the question.
Ma'am, Dr. Rekha's question was, in few instances, even when tamoxifen is not being used, there is a discrepancy between the ultrasound report and the biopsy. You don't get adequate tissue. So why is this discrepancy occurring? What could be the reason for it?
If a woman is on tamoxifen?
Not on tamoxifen.
If you're not on tamoxifen, the endometrium is thick, but you're not getting any tissue.
Yes, ma'am. Right.
Okay. So that is... then
he was on tamoxifen.
She was on tamoxifen.
No, madam's question is not on tamoxifen. It's not with reference to the case. She's asking as a doubt.
Okay, so yes, that can be, you can get inadequate tissue. In that case, you go for a hysteroscopy and DNC. So that maybe, that will give, if you curate it out, then you'll be able to get better tissue.
Stick on to your report of scanty endometrium or histopathology of whatever you get ultimately, than banking on the endometrial hyperplasia on TVS. Isn't it, Dr. Sarita?
Yes, but
now this is our third case that we are going to take. So this is Mrs. D, 57 years, menopausal for 8 years, reported in OPD with heavy intermittent bleeding per vagina for 6 months. She is average built with a BMI of 28, looking fit with controlled hypertension. There's no diabetes, no hypothyroidism. She does regular yoga and is now on some special diet for maintaining fitness for the last 1 year. So what is this history suggesting to you?
Probably she is taking a diet which is rich in estrogen containing drugs or isoflavones or something like that. In diet, that is the thing that comes to my mind, which might be causing the endometrial hyperplasia.
Yes. So that is because she wants fitness and wants to look young. And these days it's, you know, anything advertised on the net, on Facebook and all, people start trying without knowing what are the contents. So this is breast clinical exam, per abdomen, PS, PV, everything was done. Uterus on PV examination was not atrophic. 8 years post-menopause, you want an atrophic uterus, right? But it's not an atrophic uterus, but there is no other abnormal finding. Trans-abdominal scan, nothing significant. On a transvaginal 3D, multiple polyps at the fundus with a single vessel in each, grade 2 to 3 flow, EMJ is intact. On sonohystrography, multiple polyps at the fundus and both walls. Otherwise, single layer endometrium of about 4 mm. That means this, sorry for the spelling error. So actually, where there is polyp, there the endometrium is thick. Other areas, it is a 4 mm endometrium. But this is single layer is 4 mm. So 4 plus 4 means it's an 8 mm endometrium. Hysteroscopy was done, multiple polyps with spongy appearing endometrium, biopsy was sent. The histopathology was polyps with simple hyperplasia without atypia. Now, what is your line of management?
First, we will stop the medicine. Whatever she is taking.
She's not taking any medicine, ma'am. She's just having healthy food.
Basically, she's on diet. A special type of diet, she should refrain from that.
The diet containing isoflavones is it stimulates the it causes endometrial hyperplasia. So she should stop that medication first.
The diet.
Yeah, that diet containing estrogenic food. The mere fact that 8 years menopause, she has endometrial hyperplasia and polyps, multiple polyps and spongy endometrium, shows that there is a estrogen intake. Excellent.
Okay. Anyone wants to add something?
Yeah, according to me, the basic investigations have been done. Now you are asking about further line of management. One is a proper clinical examination like the per speculum, per vaginal examination to rule out the other causes. Let us not stick on to the spongy endometrium with the multiple polyps as the cause. Suppose if everything turns out to be normal, then I will suggest her two of the options. One, if it is an oral, she's ready for maintenance, then the oral progesterone, high dose progesterone, 40 milligram of medroxyprogesterone, other 20 milligram of medroxyprogesterone. Otherwise, low maintenance, I will advise her LARC, that is LNG intrauterine device. So that's
if you want to give her progesterone, for what is the duration that you will give it for?
6 months.
Yes. It is a
that is the most important thing, that it has to be given continuously for 6 months.
That is 6 months, yeah.
Yes. That is without
That is important. Without a break, it has to be given for 6 months. And you're going to call her for follow-up when?
After 6 months.
At the end of 3 months once to check endometrium. Endometrium in the sense transvaginal sonography to see the thickness of endometrium, having removed all the polyps and being on progesterone. And after 3 months, again once. If everything is fine, at the end of 6 months, I'll stop the progesterone.
She needs an endometrial biopsy.
All that is being done.
Just
You know, after 6 months to see whether that hyperplasia has regressed or not.
Yes. But if the
That
transvaginal
is the guideline. That is the
Yeah.
guideline that she has to have another biopsy at the end of
After
6
6
months.
months.
Even
Yes.
if she has an LNG-IUS inserted, even
Yes.
then at 6 months, you need to take a biopsy.
If it was atypia, you have to do it 3 monthly. If it
Yes.
was without atypia, you have to do after 6 months with the LNG device in C2. Pipal biopsy, you can definitely do.
So now we've done with basic things. Now we come to case 4, which is Mrs. N, 52 years old, menopausal for 5 years. She presents as a case of heavy intermittent bleeding per vagina for a month. She has a BMI of 36, but she does not have diabetes or hypertension. There is no family history of any kind of cancer. She has 3 children and the youngest is 21 years old. She has no addiction. She's a vegetarian. Does she have any risk factors? Does the history suggest risk factors?
Yes.
Obesity.
Obesity is the risk
Obesity.
factor.
She's obese.
Obese.
Okay. So she's obese. And what are her chances of having a malignancy?
2.5 to 2.8%.
With this weight, I had explained in the beginning, the risk is 25 times.
Yeah, I think 25%.
Yes.
So now we have done her assessment and examination. The breasts were NAD, per abdomen, nothing. PS, bleeding seen through the os. But in spite of that bleeding, the part of the cervix that we could see was not remarkable. You can't take a smear or anything at this stage. Then, when you did a PV, the uterus was 8-week size, mobile and non-tender. Okay, this is the basic gynec examination that we are going to do. Then you did a trans-abdominal scan. The uterus was enlarged with thick endometrium. When you did a transvaginal scan, the uterus was anteverted, anteflexed. The volume was 230 cc. Endometrium volume was more than 40 cc with a grade 4 flow. The endomyometrial junction was disturbed at the fundus, extending up to the cervix. Half of the myometrium was involved. The midline echo was absent. There was irregular, thick, hyperechoic endometrium seen with grade 4 multifocal flow. What does this tell you? What does this tell you?
It's case of endometrial cancer.
Maybe endometrial carcinoma.
Yes. So yours, when you do it with Doppler, it's a large volume disease. Full extent invasion in all walls is identified. Now, MRI has confirmed the uterine findings. No extrauterine evidence of disease is seen.
So it is a stage 1B. Myometrium involved more than 2/3 myometrium.
It is extended up to
Ma'am,
cervix.
it's half. It's half. It's just less than half.
But it is extended up to the cervix.
Yes, it has extended up to the cervix.
It
You will
becomes
be
a
able to
diabetes.
see the images.
And
See.
stage 2.
Can you see the vasculature?
Yes.
See the extent of the disease. This is your introitus. It has come right up to here. And if you see the wall, it has gone deeper into the wall. Very little wall is left behind. That is the extent of the disease. And this is the area up to which it has extended.
The extension
So-
into cervix comes to stage 2.
Ma'am, what is the recent guideline about that? Extension into the cervix, but not involving more than the half the myometrium does not change the staging. It doesn't change the staging. So this is, you can see the tumor, the angry looking tumor, the little bit of wall left in certain areas. And You can see it's very multifocal. The regular vessels that we see, the parallel vessels in the myometrium, they're all gone. Now the biopsy was done because for any surgery, you need a biopsy. So it was a grade 3 endometrioid adenocarcinoma. What is the surgery you would have done? This is what was done, but what would you prefer to do? Is this correct, or you would have done something else?
It's a radical hysterectomy with bilateral lymphadenectomy.
Omentectomy and staging.
Ma'am, if you remember what Nisha told you, it's only half the myometrium is involved. Not more than half.
Radical is not necessary.
Exactly. So if less than half or up to half, you don't have to do a radical. You need to, right? You've taken the periotic, which is the first one where it goes. And the HPE has just confirmed the preoperative findings. Do you want to send it for IHC? What Dr. Sarita and Dr. Nisha both have spoken about, the pole mutation, the MMR, the MRSE, the P53. Do you want to send that, and how does it affect?
Yes, we'll do it, madam. So that a low risk maybe go to a high risk. If it is a P53 mutation is present, then it will be a high risk case. So we'll do it ISC in every case so that we can reevaluate and reassess, and adjuvant therapy can be planned after.
Because as the new classification of endometrial carcinoma, what it says, what was shown by the previous speakers was that even extensive disease, if it is pole positive, has a good response. You don't need adjuvant. But if it is small disease, even stage 1 disease, early stage 1 disease, and it has P53 positive, it becomes high risk and comes back again. So this is the answer that Sharda ma'am was seeking, that we don't know what the mutations were, but if the mutation is P53 is present, it will recur, it will come back anywhere. But if it is a pole mutation positive, then whatever the extent of disease, usually it has a very, very favorable prognosis. Okay, so in this day and age, I think that is what we owe our patients, that you please do a pole mutation. If it is negative, then do an MMR. If that is, and a P53. These three will give you most of the information. This is the article that describes this, the practical ESMO guidelines. In the group, I have shared this paper. So you can download it and read it at your ease. And this is the steps it's telling you. You have the histological subtype independent. That is the most important word. Pole, then it has a good prognosis. If it is pole is wild type or non-pathogenic, then do MMR, intermediate risk. P53 wild type, then it is non-specific and intermediate. And if it is mutated, then it is a bad prognosis. So these are the basic things that we need to understand in this day and age. So a low risk stage, histopathology, and the tumor markers together will give you the stage and the prognosis. So that case, we did her mutation. She was P53 negative. She was pole mutation positive, and she's doing very well now. It's been more than 5 years. She's all good. Okay. Now we come to the last question, that we've dealt with cancer, we've dealt with polyps. Now this is the case of postmenopausal bleeding, and the report of histopathology is endometrial hyperplasia with urticaria. So now what is going to be your course of action?
According to me, all the three are fine. Progesterone, but the dose of progesterone will vary here because it is a one with ATPR. So I have to give her a 40 milligram of medroxyprogesterone uninterrupted continuously. At the end of 3 months, I have to do an endometrial sampling by people. Mirena also should be fine. The best, again, after counseling the patient, especially when if they are very scared or not ready for follow-up, etc., then simple total hysterectomy is not wrong. All the three are okay. The first option would be oral progesterone, simple total hysterectomy, and Mirena, any of these three.
Dr. Pranita, would you like to say something?
Yes, ma'am, I agree with her. Properly explaining to the patient and involving the patient, their demands, and accordingly we have to go on. And we have to take other risk factors, everything, ma'am.
Yeah, so that is important, that you need to see other risk factors, because here I have not described anything. So you have to see whether she has any other risk factors, and that would justify whatever treatment you are going to say. If she is 120 kilograms, diabetes, hypertension with atypia, I don't think anyone would advise her to go for progesterone. Please say yes or what.
Yes.
What is your opinion?
Yes, will not go for progesterone, madam.
So here the trick here is that you need to evaluate the other risk factors.
Yes.
Yes,
But
in
if
this
there is
case, it was not
comorbid
evaluated.
surgery, then also you will go for the LNG ICD will better for. If she is comorbid for any issues like coronary artery disease or anything, then also you go for a LNG ICD. That is also good in a professor. So it is not always a surgery, but other comorbid conditions, others is fit for surgery is not. That should be also counseled.
Yeah, any of the three should be fine depending upon her entire profile. That's all.
I think.
Shubha ma'am, would you like to add something?
If she is a very obese lady, and if there are contraindications for surgery, then definitely LNG-IUS is a better choice, because giving oral progesterones high doses also, there may be some risk factors to that, and therefore the locally acting LNG device would be better. But that was why it was developed, right? Because these endometrial malignancy patients are very obese, and doing surgery for them is hell. But if you need to do surgery, then a non-descent hysterectomy, might be good. You can combine it with a laparoscopic approach. Though it is difficult, I mean, there are experts, and we get all these extra long instruments to do surgery. And otherwise, non-descent, many of us vaginal surgeons are, quite adept at doing vaginal hysterectomy. So that also can be done. Because being fat and obese is one of the major problems for doing open surgeries.
Okay. Sanghamitra ma'am, you'd like to add something?
Yeah.
But any conservative management, you have to repeat biopsy every 3 months till you find that it is reverted back to normal, and then continue once a year or once in 6 months. You have to keep on continuing follow-up.
No, these patients, they do not respond well to progesterone. So the definite treatment in postmenopausal women with ATPS should be hysterectomy, unless they are medically unfit for surgery. Then you can go for this progesterone, high dose of progesterone or Mirena.
The guidelines say that a perimenopausal or a postmenopausal woman with ATPR, first line is TH-BSO.
Yeah,
if she is unfit, then only you go in for other conservative.
Other country management. Yes, that is the guideline.
Yes.
Okay. Rekha ma'am, you want to say something?
No, I
Better
also
explain the
agree.
prognosis and proper
I also
consent.
agree with hysterectomy. Like if she's really unfit for hysterectomy, then other things should be done.
Yes.
So why not?
Pranita ma'am?
Go with hysterectomy, yeah.
If there is comorbid, we are inserting Mirena in that patient. We have to explain, and with the proper consent, we have to explain everything, the prognosis to the relatives, to the patient, and with proper consent.
Okay, so here madam has brought up consent. Vanita ma'am, would you like to say something before we go on?
First option is if she's obese, even the laparoscopic total hysterectomy should be good enough under expert hands.
Vaginal can be done, no, madam?
Yeah.
Vaginal hysterectomy.
Not
While
this.
I think she has had 3 children. I mean, you have to individualize the case, but definitely vaginal hysterectomy is a good option.
better than laparoscopic hysterectomy.
So basically, these are the recommendations that every patient who presents with PMB should have detailed history, pelvic examination, including a speculum examination. Not always assuming it's the endometrium. They should be seen immediately. They don't have to stop using HRT prior to investigation. If they are not on HRT, then endometrial thickness of less than 3 mm on scan reduces the probability of endometrial pathology. And if she's on HRT, it should be less than 5 mm. Women with PMB and increased endometrial thickness should undergo more invasive testing to exclude endometrial pathology. Hysteroscopy endometrial sampling is required. Women with recurrent or persistent PMB need to be re-investigated in view of false negative rates associated with all methods of diagnosis. And it is important that there's a clear flow of information between specialists, practitioners, and patients so that everything can be explained and counseled. So before we end the session, and we are fairly on time, I thank all my panelists, experts, and even chairpersons, speakers who have stayed on to make the program, the panel more effective. So I would like to have take-home message. Vanita ma'am, we start with you because you are the first one I see on my screen.
Dr. Indra, could you please mute yourself, ma'am? There seems to be some disturbance. Yeah, Dr. Vanita ma'am, please.
She's not responding.
I
Dr.
think
Rekha Rajendra Kumar ma'am.
Yeah, my take-home message is any patient with postmenopausal bleeding should be comprehensively assessed right from the breast examination, blood pressure, diabetes, per speculum and per vaginal examination. As you have mentioned, not just see the scan report first and then go back in a reverse order and then check things. So go prospectively, make your clinical diagnosis and then proceed. And it should be a complete evaluation, complete treatment, as well as the further follow-up is also equally necessary.
Vanita ma'am, your take-home message? Unmute yourself,
please. Unmute yourself, ma'am.
Yes, ma'am. The proper history taking, and we have to find any other special diet which contains phytoestrogens and everything, and all the complete examination, and we have to proper follow-up is also necessary.
Dr. Vanita ma'am, you're unmuted. Please talk.
History of history of any external estrogen, tamoxifen, and family history of cancer, obesity, comorbidities, and proper thorough examination like per speculum and all the investigation, either a people's biopsy or a transvaginal sonography itself can detect. It can prevent so many further staging, and accurate diagnosis and management is essential because this condition is a serious one. And it can have a
Dr.
better
Pranita?
prognosis.
Yes, ma'am.
Yes, Dr. Pranita.
Yes, ma'am. The proper, right.
I think Dr. Pranita has made her comments. We can ask the, I think Dr. Varsha, are you with us? If not, we can have
Dr. Rekha Jha ma'am, you want to say something?
So the take-home message should be that in all the cases of postmenopausal bleeding, we have to go for the histopathology because it is a serious condition might be there, but the counseling should be done as most of the cases are because of atrophy. So the patient should not panic. And so the low risk patients and the patient profile seeing at that we should talk about it and just tell them that, look, you have got this, this might be this and this, but don't panic, because unless the biopsy report comes, you have nothing to panic, as most of the cases will not turn in cancer. So you have to just counsel the patient and go for the biopsy and then follow the guidelines.
Thank you,
Dr. Varsha, ma'am, you want to add something, Dr. Varsha?
Yeah, I totally agree with Rekha ma'am. Actually, we all the patients should be investigated very meticulously, and we have to follow the proper protocol. That is, we have to stick to all the protocols and regimens, and we have to follow, and that will lead us to the diagnosis. Because we cannot leave. If one patient is left, then of course we are at this way, like we have left one patient. So we have to consider it seriously accordingly. So everything has been explained very beautifully. And thank you, Asha ma'am, for offering us this platform.
Shubha ma'am.
Yeah, so I would like to say that, everything will start with the adolescent girl. Because now even CA endometrium, all these PCO patients having the metabolic syndrome and the risk of CA endometrium is increasing nowadays. Though CA cervix is coming down because of so many other things. So we have to educate our girls right from the adolescent age that, a good lifestyle, maintaining their weight, treating any other condition, comorbidities, diabetes, hypertension at the correct time, and lifestyle change and physical activity, maintaining ideal weight is one thing that has to be emphasized. And CA endometrium is eminently treatable if they come at the first symptom, because we can catch it early. Of course, unfortunately, if the histopathology is high grade type, then it is sad, but otherwise early surgery and intervention, even conservative treatment can be given for CA endometrium people. And we should not forget about CA endometrium in the younger girls, especially nowadays the obese PCOS girls who have a lot of menstrual abnormalities come with hyperplasia. So it's very important to suspect and do diagnosis even in the younger people, not only in postmenopausal bleeding.
Thank you, ma'am.
Dr. Sanghamitra, ma'am.
Dr. Kokre, sir, you want to add something? You've been
No, ma'am.
here.
Yeah, actually wonderful, very nice. And I think evaluation, as ma'am said, is that making awareness is, I think, the key, that diagnosing them earliest and would be the right thing to deal with this kind of patients, and so that we can give them the right treatment for them and make their life live long, that is what I think.
Thank you, sir. Thank you, sir.
Thank you.
Dr. Mausmi, Dr. Bibha.
We have
Dr. Sarita, you are still there.
Dr.
You want to
Sanghamitra
just
also.
say something before I end the session?
Even a simple, a pap smear can have some atypical cells. So any type of screening should be offered. So it can have atypical cells from the endometrium. So screening, you should go for screening and tell the patient every time.
Yes, ma'am. Dr. Sarita, you want to add something? You've been here so
Yeah,
long.
Yeah, I think yes, all the points I think have been really clearly emphasized. Yes, and the pap smear and looking at the cervix is so very important, because a lot of times that is the only symptom they're coming with, and they've had for discharge they've had antibiotics and whatnot they have been given, and just nobody has put in a speculum. So that's the first and foremost thing I think all of us have to do. Any lady coming with postmenopausal bleeding.
Yeah, so that was the first thing I put up,
yeah.
see, to put in a speculum and have a look.
Yes,
Always have a look. So I thank everyone. I request with folded hands, please support my candidature for Food, Drug and Medico-Surgical Committee. I thank all of you for being here with me this evening, spending this precious holiday time with us on such an auspicious day. Thank you, Dr. Sujaya. You want to say something?
No, I'm good, ma'am. I think everything has been covered. So it was a very good panel, very informative at the end of the day.
So thank you so much. Thank you Corona Remedies and Mehul for being with us. And thank you all the delegates who have logged in and because of whom the program becomes worthwhile. So I thank everyone, the chief guests, guests of honor, the chairperson, the speakers, the panelists, the experts, my convener, everyone. Thank you. I hope your evening was well utilized. And we will be having obstetric Doppler next week. So you will get the link. I request all of you to log in and see what a gynecologist needs to know about obstetric Doppler. Welcome, welcome again. Thank you, namaskar. Happy Vasant Panchami.
Thank you, and all the best wishes
Thank
to
you,
the
Dr.
people who are going for the election.
Thank you.
I
Thank you,
think
ma'am.
someone else, Asha, is also.
Yeah.
Thank
Thank
you.
you for
Mehul,
the
you may end the
Dr.
session.
Sarita
Best
ma'am
wishes.
also. Yeah.
Yes.
Thank you, ma'am.
Dr. Sarita is going for gynec oncology.
Okay, yes. Thank you for
And-
reminding me, Dr. Sarita.
And I'm going for
Thank you.
Food, Drug
Thank
and
you.
Medico-Surgical Equipment Committee.
Yes,
Best wishes.
best wishes.
Thank you. Thank you.
Thank
Thank you,
you,
Dr.
everyone.
Asha.
All
Thank
the
you. It was
best.
a good session.
Mehul,